And so we'll get started. For those of you who I don't know, hi, I'm Elizabeth Wallace, Executive Director of Mobile Healthcare Association, and we're so glad that you could be with us today. We started a partnership with Beyond Type 1 earlier this year. They're a wonderful organization focused on diabetes research, education, and we are excited to have Mariana Gomez from Beyond Type 1 with us today to introduce their organization and our today's trainer. Mariana.
Hi, thank you, Elizabeth. It's been a pleasure for us this year to work with Mobile Healthcare Association. It's been a real amazing partnership. We've been working together for almost a year now, and we are very, very happy today bringing this presentation to you. We're Beyond Type 1. We're a nonprofit organization. We're dedicated to the diabetes space. We were founded in 2015, almost 10 years ago. We're very close to celebrating our 10th year anniversary, and we're dedicated to the diabetes community. We were co-founded by Nick Jonas and Juliette Bobogny. They are change makers. We serve the largest diabetes audience of any nonprofit in the diabetes space. Or digitally, we reach more than 5 million individuals, and our resources have been translated into more than 9 languages. We help people with type 1 and type 2 diabetes for as long as they're secure. We want to reach and find the cure as soon as possible. And while that happens, we share resources in a way that people can thrive and not only survive with their diabetes. We have different programs. We have global campaigns. And of course, now we're working on the grounds, thanks to organizations like the ones that you are members to. So it is a pleasure for us to have you here. And I'll let Lucille, if Melanie's not here, Melanie and Lucille, please introduce yourselves.
Wonderful. Thank you, Mariana, and good day to everybody. I am Lucille Hughes. I'll be your facilitator for today. And my credentials, I have my doctorate in nursing practice, my master's in nursing and in education. But more importantly to you, I am a certified diabetes care and education specialist and board certified in advanced diabetes management for over 38 years. And I am the principal owner of Diabetes Insights LLC, which is a web platform and organization to help individuals learn more about diabetes, both the healthcare professional and the community. Mariana?
I believe that Melody's in the waiting room.
Oh, okay, great. Do you want me to just continue with the presentation for now? Sure. So what we're looking at is the idea of diagnosing diabetes. We want to not miss anybody. This journey continues because we know by missing a diagnosis, it usually can end up in an event such as DKA or prolonged undiagnosed, like in type 2, which could lead to comorbidities. Next slide, please. So this slide is really important. When you look at over 800 million people living with diabetes across the globe today, and 9.5 million are living with type 1 diabetes. Now, if I could direct your attention to the right side of the screen here, the top number is, I think, something noteworthy. For 40% of adults diagnosed with type 1 diabetes were originally diagnosed with type 2 diabetes. This is because, number one, so many people, including healthcare professionals, still associate type 1 diabetes with children and adolescents. We know, all of us on this call, that type 1 diabetes can be diagnosed at any age. However, the older the individual gets, the more likely they're going to be misdiagnosed with type 2 first. And what does that mean? That means a delay in insulin administration, insulin therapy. We're going to talk more about that in just a little bit. Half of people living with type 2 diabetes don't even know it. When you're talking about the signs and symptoms of diabetes, think about that. Increased thirst. I could talk my way around that, right? Add some salty food, whatever. Increase urination. Well, I'm drinking more, I must have to urinate more. Weight, so not having enough energy. Well, I'm tired, I'm getting older. So many of the signs and symptoms of diabetes are insidious, so people don't really want to react to them. That doesn't help us with those seeking care to get that diagnosis. And on the bottom, 46% of children, 46% are diagnosed with type 1 diabetes in crisis. What does that mean? In DKA. Unfortunately, only one episode of DKA impacts mortality. So we need to prevent that. Next slide, please, Mariana. So let's start. We're going to talk about type 2, and then we have a slide on type 1. So when you're looking at type 2 diabetes, we know that this builds over time because this is the disease of insulin resistance versus type 1 of insulin deficiency. So here with insulin resistance, even though the body is able to make insulin, the ability to do so can deteriorate over time, not because of the same cause of type 1, but it can deteriorate those beta cells, those cells that are our insulin producing cells can disintegrate. They're going to be destroyed over time. But also we know the resistance is on the cellular level. So those individuals that have weight to lose, or we call them in larger body individuals, that excess fat is blocking the receptor sites on the cells where that insulin is supposed to, that lock and key theory, open up the door, push the blood glucose inside so we can burn it for energy. So this happens over time. There's genetics involved, age, history. Pre-diabetes obviously is a precursor to type 2 diabetes. And I will say everyone with type 2 diabetes has gone through a pre-diabetes state, even though they may never have been told or recognized or identified in that state. And those, of course, living in larger bodies. We also have to look at the world, the economy, socioeconomic risk factors. We know that those that live in maybe an unsafe place to get fresh food or to be physically active can impact their development of diabetes. Next slide, please, Mariana. So with type 1 diabetes, we know that this is an autoimmune disease. That's going to play a really important part in this presentation today. So it's an autoimmune disease, and we all know autoimmune disease, right? So we have lupus, multiple sclerosis, celiac, all these where the body, for some reason, sounds vague because we still don't know. If we did, we would have that cure. But for some reason, the body is invaded and the body sees the beta cells, in this case, in type 1 diabetes, it recognizes the beta cells as foreign objects that need to be destroyed and turns on itself and starts to destroy or eliminate the beta cells, causing high blood sugar that we obviously can lead to complications. Next slide, please, Mariana. Thank you. So there are a lot of things that Beyond Type 1 is doing. I am so privileged to be partnering with Type 1 to bring this information to people like you and to the community at large. One of the projects, See the Signs, Type 1 Diabetes, is taking these insidious little symptoms, right? These symptoms and signs and symptoms of diabetes, because they're the same for both Type 1 and Type 2, but putting it out there in really clever, innovative ways to raise the awareness of not only healthcare professionals, but the community again, to say, hey, if you have any of these, just get help. Look at them, take them seriously. That excessive thirst, frequent urination, unexplained weight loss, exhaustion, and understand why. It may be nothing, but it also might be diabetes. And then there's other symptoms that they may notice, such as frequent urinary tract infections. I like to add in there also yeast infections are common in females. Diagnosis of diabetes because of that sugar. That sugar they're eliminating through the urinary tract acts like a buffet for bacteria, for yeast and bacteria. Blurred vision. We know that the glucose attached to the vessels, the tiny vessels, and how it affects the tiny vessels in our eyes when it's moving through our blood system. Dry and itchy skin, poor healing, that we do see over time, but it can occur and obviously is another symptom. Next slide, please. So what should everyone know about DKA, diabetic ketoacidosis? We want to raise awareness because, again, this is about preventing DKA. But what does it look like? What are the warning signs? Obviously, ketones. whether in urine or blood. Today we can measure both urine and blood ketones. Nausea, vomiting, abdominal pain, that fruity smell like acetone. I tell patients it smells like nail polish remover. Rapid breathing. We know as healthcare professionals, Kussmaul's respirations. That's rapid breathing that we see people at deep rapid breathing in acidosis. Flushed skin, lack of energy. Again, you have these high blood sugars, 350, 400, 450. When we're measuring blood glucose, think about what we're measuring. We're actually measuring the amount of energy, right? Because glucose is energy, the amount of energy that the body has, but it's in the blood. It's not in the cells, the muscle cells, particularly where we want to burn it for energy. So we have this high blood sugar. I just had to do a lecture this morning. I was trying to explain this to some lay community. I said, think of it as like having 20 gallons of gasoline outside your car. You need to get the gasoline in the gas tank, or else you're not going to move. Same thing with our blood glucose. By having hyperglycemia, high blood glucose levels, that's our gasoline, right? Blood glucose is our gasoline. It's having our fuel source outside the gas tank, which is our muscle cells. So we feel drained. We don't have that energy, potential energy, but we can't use it. Next slide, please. So at type 1 diabetes, it doesn't have to end in a DKA situation. You'll see a slide coming up where we call it crash and burn. It's an analogy that we're kind of using today to bring home that point that we want to assist individuals of all ages that are at risk for type 1 diabetes to do a safe landing into type 1 diabetes, not a crash and burn. And what that means is we don't want them diagnosed in DKA. So there are things that we can do. These autoantibody screenings can identify those at high risk for type 1 diabetes. We can monitor them. We can teach them the signs and symptoms. We can provide treatment if necessary and really, really get them to a nice, smooth landing. Unfortunately, you're noticing, I'm not saying yet, prevention of type 1 diabetes. We're not there yet, but hopefully someday we will be. At least we have some wonderful treatment to delay the onset, and that's what we want to talk about today. Next slide, please, Mariana. So as mentioned, I am from Diabetes Insights. It's my company here, and I am so pleased to present more information on this topic. Go ahead, Mariana. And I was involved in the consensus guideline, which is what we're going to talk about now. Consensus guideline screening and monitoring for early stage type 1 diabetes. Next slide, please, Mariana. And you can move on. That is me. There we go. I want to thank Breakthrough T1D for helping me create this original slide deck, which we have altered a little bit to make it appropriate for your viewing, but they are the creators and we want to thank them with permission. We have their permission to use these slides. Next slide, please. Great. So really the objective of this program is to explain early screening for early stage type 1 diabetes, define the stages for you, discuss the monitoring. What does that look like for children and adults? Summarize the psychological support needed and education needed, and identify knowledge gaps and future directions. Next slide, please. Okay, great. So let's get into the screening for early stage type 1 diabetes. Mariana, thanks. Okay, so who are we looking for? Who are we trying to identify? Well, family members of persons living with type 1 diabetes. Again, the guidelines outline this very well, but if you think about this, type 1 diabetes, again, is an autoimmune disease. We see autoimmune diseases in families. So we want to take and really raise awareness to any individual with type 1 diabetes and encourage them to have their family members screened. Could be their siblings, could be their children. Everyone should be screened. persons at high risk for genetic risk. So we're looking at research screening. So there's studies being done on this population and cohort. For me, I personally have a lot of autoimmune diseases in my family. And the closest I have is my sister who has celiac disease. Now that's an autoimmune disease. So I encouraged all of her daughters and grandchildren to be screened for type 1 diabetes, as well as myself and my siblings. The third bullet there, persons identified through general population screening program. So we're starting that similar to now the mobile clinics. Hey, come get screened. Let's cast that net out and see how many people we can identify and really give them that soft landing. And then, of course, persons identified through general practitioner clinics and office visits, raising awareness to family practice practitioners, endocrinologists, diabetologists to say, this should be on your radar when you're looking at individuals to think about and identify individuals for screening. Next slide, please. So why? Well, I mentioned this. We want to prevent the ER admission. We really want to create that smooth landing. We know that we are so excited that there are advances in type 1 diabetes, and you've probably known from the past, we have over 25 different treatments that we've tried to delay the onset of type 1. We're going to talk about Tzield in a little bit, but we really we feel more powerful than ever to say, we do have a wonderful therapy that can delay that onset. And I often think about my practice and over my 38 years doing this, I worked in the pediatric population. The youngest child I put on an insulin pump was a year old. He was diagnosed at 10 months old. And I've treated patients, my oldest patient was 78 years old. Now, I look at these individuals across that lifespan and I think back, had that 1-year-old been able to have a delayed treatment, so a treatment to delay onset, maybe we could have gotten him to 3 years old or 4 years old, or have that adolescent, maybe get through adolescence without this diagnosis, or that young adult going off to college. Maybe we can give them their college years free of type 1. So it's really, really important. Yes, we don't have a cure, but this is a very powerful treatment to delay the onset. We also want to avoid misdiagnosis. As mentioned before, we see it more so in the older population. I can think back to 1988 when I was really first starting in this field. A 33-year-old, very lean, very fit individual came into my endocrine practice. And I thought, wow, he doesn't look like the typical type 2 patient. And I was looking at blood work, obviously at diabetes, and I turned to the endocrinologist I worked with. I was very new in this space. And I said, so how unusual is this to have somebody look this lean with type 2? And he says, well, first of all, only 80% of type 2 are in larger bodies. There's that percentage that are very lean. But second of all, this individual has type 1 diabetes. And that was the beginning of my passion to really raise awareness that type 1 can happen at any age and how important it is to identify it early. Imagine delaying that individual, putting him on oral medication when he needed insulin. Next roll, please. Next slide, please, sorry. So when we look at the screening for autoantibodies, we're looking specifically for islet autoantibodies, again, beta cells and islet cells. Right? So we're looking at autoantibodies, particularly insulin autoantibody, islet antigen 2, zinc transporter 8, and glutamic acid decarboxylase, or GAD65 as we know it. Next slide, please. So really exciting to go over some screening programs that are existing now across the country. We put their logos here as well for you so you can recognize them if you came across them. So we have Diabetes TrialNet, very, very popular, well-known program for people that are wanting to get screened. And you can see here in each of the boxes, we put the criteria in the community in which they serve. So it's a free study. Persons with family history of type 1 or previously positive autoantibody testing. You get a mail kit to do at home. The ASK program, well, and that's an autoimmunity screening for kids. That's what ASK, the acronym, stands for, but also for patients and parents. Free screening for type 1 and celiac disease in general populations 1 to 99 living in the US. This is also a home testing study too. And they particularly cater towards Colorado. There's Cascade, Washington State screening program, and they're screening for type 1 celiac disease, and they have the criteria there for newborns and children. The Pledge program out of Stanford Health program, and they look at genetic risk scores in newborns again and young children for both celiac and autoantibodies in high-risk genetic individuals. And of course, laboratories. We can have your prescriber write a prescription to have these autoantibodies checked and tested. Mariana, next slide. So let's get into staging of type 1 diabetes. So here's the life cycle, that journey through or to diagnosis. We always start with a genetic risk. We know that all individuals that develop type 1 diabetes start with a genetic risk. Then there's this immune activation. The beta cells are attacked again. Sorry to be vague, but yet we don't know. Again, is it a viral condition? Is it environmental? What happens here? But what we do know is that there is an attack on the beta cells, and then there's an immune response. You can just keep moving along, Mariana's, be fine. Sure. Great. So the immune response is the development of a single autoantibody. So very important. We're looking for 2 or more, and we're also looking for persistent autoantibody positivity. So here we have 1. We're going to still monitor and watch this individual, and then they may progress to stage 1 of type 1 diabetes, which is 2 or more autoantibodies, but blood sugar levels are still within that normal range. This is really where we want to monitor this individual very closely, and we'll ease them into stage 2, great, which is 2 or more autoantibodies and abnormal blood sugars. So it's at this point with this mild dysglycemia that we will want to offer that delayed treatment, which would be TZL tocilizumab for these individuals. And then stage 3 is the clinical diagnosis. Now they meet the clinical diagnosis we know is fasting blood sugar 126 or higher, random blood sugar over 200, or an A1C of 6.5 or greater. And stage 4 is those living with diabetes for 10, 20, 40 years, so long-standing diabetes. Excuse me. Now I want to bring you back to, next slide, please. Stage 2 and 3, we have divided them into subsections, and just take a little sip there, sorry. So we now have stage 2, which is A and B, and stage 3, A and B. And they're really defined by the amount of or level of dysglycemia. So we look at mild versus profound in stage 2, and of course, stage 3 is asymptomatic. We may not even start insulin yet, depending on the variations in their blood sugar versus symptomatic and that need for insulin. We don't want to delay that. Next slide, please. So we do know, as I mentioned, that everyone diagnosed with type 1 diabetes has a genetic risk, and the population is about 1 in 300. Now, next slide, please. When we look at families, we see that family members are 15 times greater. They have greater risk and risk of relatives. So now my extended family would be 1 in 20. Now we're going to talk about what does that monitoring look like? So we've identified these autoantibodies, and what should we do? Who should be monitored? So any child, adolescent, or adult who has tested positive for islet autoantibodies in early stage 1 diabetes. So we know again that nearly 100% of individuals in early stage type 1 diabetes with 2 or more, this is a key word, persistent, because they can wax and wane, islet autoantibodies will progress to stage 3 or clinical diagnosis. Next slide, please, Mariana. Thank you. So we created this consensus guideline to help individuals like yourselves to say, okay, so I need a document. What is the guidance from me to bring my patients through this journey? So we created this for you. I'm very, very honored to be an author on this paper here. Next slide, please. That consisted of 73 international experts over 4 continents and 11 partnering organizations got together to create this guidance. Next slide, please. Which has been published in 2 major journals. And again, you can go there for this particular publication. Next slide, please. So who's involved in monitoring? I like to say, yeah, we're going to give you a list here, but everybody, everyone, that's what I like to do. I want to stand on a mountain and kind of yell out, hey, if you know anyone with type 1 diabetes, encourage those that are related to them to be screened. And for those having symptoms, we want to raise awareness, but primarily, obviously, we're going to target primary care physicians, specialists, diabetes behaviorists, individuals in early stage type 1 diabetes. Certainly want to bring them into the call of action here. General endocrinologists, diabetes care and education specialists like myself, and the 19,000 others of diabetes specialists like myself, public health specialists, and allied healthcare professionals. Next slide, please, Mariana. So let's start with monitoring for children, and then I'll go over the adults as well. So the first thing we want to do when we have a child that is positive for autoantibody, first, let's confirm it, right? Let's make sure that this is true. And we want to start education now. I will tell you, I'll talk a lot about education, but if you walk away with one thing, the reason is to, number one, we are not with these individuals, these families, these children. We're not with them 24 hours a day. In fact, we rarely see them in the scheme of their year, right? All the hours and minutes in the day, we're not with them. So they really have to understand the importance of what we're trying to do and what we're trying to prevent. However, we don't want to use scare tactics. We really want to make sure that the education psychologically is supportive and does not increase fear and anxiety. But they should know signs and symptoms of type 1 diabetes, signs and symptoms of DKA, and to really reassure them so we can identify them and have a smooth landing and be here to supportive for them. So children, I'll go back just one second, Mariana. Children under 3, we're going to monitor their autoantibody status every 6 months for 3 years, then annually. No progression, we can stop. And you'll notice too, the younger the child, I want to mention this as well, the younger the child, we see the fastest progression. It takes longer for an adult to progress on, but very, very fast for younger children. So you'll see as I go through the monitoring, we spread it out, we slow it down with age. So children greater than 3 years, we're going to check them annually for 3 years. Then if no progression, we don't have to worry about it as much. Next slide, please. We want to perform metabolic monitoring. So what does that look like? You know this. Blood sugars, right? We can monitor blood sugars, hemoglobin A1C, look at changes in A1C, that 10% change. We want to look at and say that should be a red flag for us. And then we tailor their risk based on age. So as I mentioned here, less than 3, 3 to 9, greater than 9, again, slows down as that child gets older. Next slide, please. Really reinforcing education, the need for monitoring. They might say, oh, but their blood sugars are normal. Why do I have to do this? Offering them types of monitoring that work well for them. So we can think about CGM use, right? That might be something more conducive to what they want to do rather than finger sticks on a younger child. Maybe an adult doesn't mind doing self-monitoring of blood glucose, but at least today we have lots of options to offer for this monitoring stage: oral glucose tolerance tests, blood tests, things like that. Next slide, please. So in stage 2, remember stage 2 autoantibodies, dysglycemia. Okay, stage 2 of type 1, 2 autoantibodies, persistent dysglycemia, please refer to a specialist. Educate the need for monitoring signs and symptoms of DKA, safe landing, provide written instructions. They're hearing a lot that their fear is the anxiety is going to increase, so they need something when they go home to refer to. Give either self-monitoring, a blood glucose meter, that's the SMBG, strips, could be CGM, what have you. Next slide, please. Great. So just so you note, in this guidance, we do not get into when is it appropriate to start insulin. We leave that up to the provider, and that's going to be based on dysglycemia and variations in blood sugar. Next slide, please. Let's talk about monitoring for adults because it's going to look differently. Why? Why does it look differently? Number one, we haven't studied a lot of adults. We've studied a lot of children with type 1 diabetes, but unfortunately, we have not studied a lot of adults, even though they exist. They are often misdiagnosed. As I mentioned, that happens a lot. They progress more slowly. And let's not forget about LADA, latent autoimmune diabetes of the adult, which again is that autoimmune type 1 diabetes. Next slide, please. So why are these individuals misdiagnosed? As mentioned before, as the age increases, providers are less likely to think of type 1 diabetes, right? But yet, because of that, it's an inverse risk ratio. Their risk of age goes up, and so does their DKA risk, because if we're not diagnosing them, there's a greater chance they're going to end up in DKA. There's limited awareness amongst HCPs about this population. But look at this statistic, 30% diagnosed with type 1 diabetes are over 30 years old. But yet, 40% of those individuals were first diagnosed with type 2 diabetes. So we are missing a lot and misdiagnosing a lot. Next slide, please. So what does it look like for adults and how do we monitor them? Always want to confirm. We'll confirm with a second sample. Now, remember that persistent word I use. If transient, that single antibody is transient, you can possibly stop monitoring. But again, we've raised awareness. We want to be aware and we can look for those symptoms if they were to rise. Annual metabolic monitoring also. Again, if they have a first degree relative with type 1, having any dysglycemia, history of stress, hyperglycemia, otherwise perform every 3 years. I also want to mention here, and I will mention as we move along, we want to be particularly sensitive to that child or the adult that is at high risk when they get ill, because we know the stress, right, of illness on metabolic control or glucose management. And that could be that straw that breaks the camel's back. So we want to be really sensitive during periods of illness to increase monitoring. Next slide, please. So again, confirm another sample, giving them opportunities for monitoring, whether it be self-monitoring, CGM. Again, check for illness and symptoms. We want to make that sensitive or that red flag time in somebody's life when they're ill. Oh, that could be it. We notice through history and time that there's that little uptick in a curve of children being diagnosed with type 1 diabetes, and it happens during the fall. Well, you think back, what is it about that season? Well, they're going back to school. They are in with other children. They get sick. They get the colds, the Coxsackie, and boom, it looks like the fall causes type 1, but it's that illness that triggered this response. It was just too much for the body to make insulin with the very few beta cells they had left. Looking at A1C over time, primary care visits and monitoring them. And again, change in that A1C is something we want to look at also. Next slide, please. So refer, just like we said with children, if we're seeing these autoantibodies, refer to a specialist, to an endocrinologist, monitor metabolic status, whether it's A1C or use your A1C or your OGTT, so oral glucose tolerance test, looking at changes in A1C levels, and also C-peptide assessment. I just, again, did that presentation before, and, we don't talk a lot about C-peptide levels, and yet they're really important, because what we know about C-peptide, and what you know, obviously, as providers, is that C-peptide chain is going to tell us what their ability is to make insulin. When I explain it to my patients, I use analogies such as a banana, and I tell them, when you make insulin inside, endogenous insulin, when you're making them from your own beta cells, insulin has a chain, but the leftover chain is the C-peptide chain. So you use up insulin, but the garbage left over is that C-peptide chain. And I use a banana and I peel it, and I say, we eat the banana, that's your insulin, but the banana peels is the C-peptide chain. So if I want to know how much insulin you're making, I'm going to measure all the banana peels to see what that is. And they can see that, they can understand that. Next slide, please. So let's look at some other considerations like psychological support and education. So what's the big deal about beta cell function? But obviously it's a very big deal, because we know as that beta cell function starts to decline, that's the trigger for us to say they need insulin, because we need to support the beta cell function. Next slide, please. And again, using C-peptide helps us. Here's a C-peptide test, again, measuring all those banana peels to see what is the ability for the beta cells to produce that hormone insulin. Next slide, please. Psychological support in the next slide, not to move yet, Mariana, but the next slide go together as far as the education. So we really wanted to, when we put this consensus paper together, we really wanted to make sure we highlighted the importance of keeping the psychological impact of screening first and foremost in this whole process. So hand in hand with what we're doing. Yes, it's fascinating. We want to identify, we're doing such wonderful things, but we need to think about the psyche. What kind of an impact is this having on the family or that child, that individual, that adult? So allowing them to ask questions, to provide that emotional support, to that empathy, to say, I understand what you're going through, and I'm here for you to walk this journey with you. Next slide, please. Education, again, not just the psychological support, but we want to give them the written education, the knowledge, the skills, the tools, and the knowledge to be successful during this journey in time, and have a positive mindset. Next slide, please. So we are making progress. Next slide. We are. Great news is we now have codes we can use for screening. We have diagnosis codes. We can say this is what an individual has, and we can order these autoantibodies. We also have the not preventative, we have the delayed treatments. I always catch myself. I would love to say prevention. Next slide, please. And as mentioned, we have TZIELD, tocilizumab, which is a 2-week infusion that we can give an individual to help delay the onset of stage 3 type 1 diabetes. And this treatment is available for individuals 8 years and older. However, there are studies being done. I know every day there are studies being done, and I am hopeful that in 2026, that age group is going to be much lower. So again, research is powerful. Next slide, please. We still need a cure. I always say, I've devoted my life, my career to being a diabetes specialist, and I'd like to be put out of business. So we still need a cure. Next slide, please. And as a reminder, the road to success is not easy to navigate, but with the hard work, drive, and passion, it's possible to achieve. And that's what keeps me motivated to come to work every day, is knowing that I'm working with individuals like yourselves with Beyond Type 1, Breakthrough T1D, all these associations and organizations that are here to improve the life of somebody living with diabetes. So let's talk about some screening resources. So Mariana, would you like me to go through these, or were you or Melanie going over them? What would you like to do?
Yes, of course. Thank you, Lucille, and thank you everyone for all your time and your attention here. These are some of the resources that Beyond Type 1 has been working on for the last couple of years. And actually, we have Melanie here. Melanie is part of our social impact and global advocacy team, and she might be able to share a little bit more information about what kind of resources we have in our web pages and other elements that might be useful for you and your teams.
Hey, sure, absolutely. Thank you so much. And thank you, Lucille, for that really in-depth, deep dive information. So at Beyond Type 1, we have a variety and a whole host of resources related to both type 1 and type 2 diabetes. And I would say most relevant to this conversation, we have toolkits for early detection of diabetes. And then we also have fairly hot off the press, newly created toolkits for after screening. So a lot of good guidance in easy to understand language that you can share with your community members. And then another resource that has been really well received here recently is a toolkit for the newly diagnosed. Again, we have that for type 1 and type 2 in English and in Spanish. And so all of those things can be accessed on our website.
Great.
And it looks like, yep, Mariana shared a few of those resources. Thank you so much. And I believe someone asked about this slide deck in the comments, and I do think that we can probably send this out. And so these QR codes will get you to where you need to be once you have the deck.
And as part of the final part of this deck, would you please scan the QR code? This is for us to make our presentations even greater than what they were. Lucille, this was a great presentation, and we would really, really appreciate if everyone could take out their telephones and scan the QR code. This is a post-session survey. It won't take you more than 5 minutes, and it'll help us do our work better in a different way. So we really, really, really appreciate it. And then I'll let Lucille again take the microphone for us to continue with our sessions.
Yes, we're not done. We still have some more to cover as far as what the screening looks like. So please don't leave us yet.
Lucille, do you want me to use the next deck, or
Yes,
you use
yes,
yours?
please. No, please. That'll be fine. Yep. And when we're done with the deck, everyone, just so you know, we're going to do a slide deck looking at what the screening looks like. And then we'll have Mariana close the slide deck so I can come in full screen. And I'm actually going to do a demonstration for you. So just bringing all this information to life. So first we'll go over it, then I will demonstrate it for you.
Ready? Can you see my screen?
I can. Great. Wonderful. Next slide. Okay. All right, step-by-step guide for screening. Yep, everyone knows me already. Good, that right here. Thank you, Mariana. Okay, so when you get the spot collection kit, it's going to include these ingredients here. So it's going to be the kit box, and I'm going to be in full screen. I'll be showing you everything. So we'll just follow through with the PowerPoint first. You'll have a dried blood card, so I'll show you where to put the blood on it, a gauze pad, Band-Aids, pre-labeled return mailer, sterile alcohol preps, they give you 2 of those, test requisition form, and the contact activated Lancet that just have to press, and you get 3 of those, which is very helpful. Next slide, please. Okay, so first thing, obviously, we're going to greet the patient. Hi, welcome to the screening, provide a brief overview of the screening process and the procedure, letting them know that it is a finger stick. It's a dried blood test. looking for the islet cell antibodies and having them understand that these cells make insulin. And in the early stages of type 1 diabetes, these cells come under attack and our bodies make antibodies against them, which is important for them to understand. That leads to type 1 diabetes. And with this simple blood test, we can determine if those autoantibodies are present in that particular individual for type 1 diabetes. Next slide, please. So what we're going to do is we would open up the test kit, and you will find the test requisition form. And as you can see on here, you'll see on the right there, it says page 1 of 7, written in red there under the patient information. So as you go through this, and you can use the slide deck as you get used to this, and I'm telling you, it's so simple what you're going to see. Very, very simple. But you can use the slide deck to guide you into what frames you actually have to fill out. And I filled one out for you today as well. Okay, write clearly. I would personally write for the patient. We've seen many different penmanships around. So I would write very clearly yourself and have the patient verify the information is correct. Next slide, please. Okay, so it says here, this is why you want to have the slide deck. Fill out pages 2, 3, and 7 with the patient, which is the patient contact information, ordering clinician information, you'll know that, sample and test information. You do not have to complete 4, 5, or 6. And it tells you that right there. And as you can see in this picture, each of the frames are labeled. Couldn't be simpler. Next slide, please. So now we go over how to perform the test. Obviously, you're going to be washing your hands and putting on gloves. I'm going to tell you, I'm not going to put on gloves when it's my turn to demonstrate this because I'm sticking myself, but you would. Ask the patient which finger do they prefer that you use. Sterilize the selective finger with the alcohol. Remember, you're getting ready to do a finger stick. Open the lancet. You'll see by just twisting it. Position the blood spot card easily next to you. And then quickly and firmly press the lancet against the side of the patient's finger, and then gently apply pressure, encouraging blood flow, milking the finger from bottom to top. I'm a real stickler on that, doing this for many years. I've seen so many people actually squeeze the finger, even patients, they squeeze it on top, and what they're doing is they're acting like a tourniquet, and they're not getting a good drop. So we want to milk the finger up, that blood flow like your heartbeat, ba-boom, ba-boom. You're going to get a beautiful drop of blood. Next slide, please. Then we want to fill in. You'll see on the card that the card has 5 circles on it. You need 2 or more, so no less than 2. Try to get 3 or more. And you want to fill in that full circle area. You don't want just a drop of blood. You want to make sure that the blood does touch the dotted circle perimeter. And then you want it to dry, which I'll show you. The card actually has a little stand, so you can put it to the side to let it air dry. It says for 30 minutes. You don't have to do it for 30 minutes because it's going to dry quickly. Next slide, please. Okay, then obviously you're going to care for the patient. Apply the gauze to the finger, make sure it stops bleeding. Once it subsides, put a Band-Aid on the finger as well. Next slide, please. And then patient information, next steps. Inform the patient that the results will be returned, and you will determine how you're getting those results, if the patient's getting them directly. And I guess Mariana and Melanie, you can determine and help these the mobile clinics here with how they're going to receive those results to get back to the patient. Okay, and packing the sample. So I will show you that again, it comes with a packing bag. And as usually in these screening programs, you're going to be collecting all the boxes in those individual bags. You'll be collecting all of them, which will go into a larger box, which you're going to see in just a second. Next slide, please. Okay. And that box will be mailed together, not individually. And usually, again, think about if this could be sent to a patient individually, they might mail it in that one mailer, which I'll show you, but you're going to be collecting all of them and sending them out as a group. Like that. There you go. Really, really simple. Next slide, please. Okay. So, great. Mariana, if you can, there we go. Okay, so am I full screen now? Can you see me full screen? Everyone? Good, hopefully. Okay. I am going to go through the steps here. I'm going to be mindful of the
You're muted, Lucille.
Sorry about that. I don't know how that happened, but so I'm going to try to be mindful of the camera. Mariana, if any point you cannot see what I'm doing, please let me know, okay? So I want to make sure everyone can see this. So here's the box, here's the actual kit. And as you can see here, it comes in a plastic liner. I got something started for you so that you can see. So it comes in a plastic outer lining, and then I'm going to open it up and take it out here. So here you see the 3 Lancets that it comes in, and I'm going to take out each thing. So my direction card. Here's my little bag that I have. I'm going to take this out, and you can see that I have Band-Aids, 2 Band-Aids. Get that ready. Alcohol, get that ready. And sorry, I should be doing this on camera. And the gauze that I'm going to have ready as well. Okay. In my box, this is the individual bag. Now, remember, it has postage on it, but you're going to be collecting all of these individual kits and putting them in a larger box. But I would like, you can still use this to collect them, but then put them in a larger box. So this comes in the box as well. Now, here's the card I was telling you about. So you are going to fill out this first section here, trying to be mindful. Okay, oops, hold on. Just let me get this right for you. Okay, here we go. Here's the front. And then the first section, which it says 1 of 7 is my name, right? My gender, date of birth, and if I have a history of anyone in my family with type 1. Then I'm going to move on. It says, and if again, following the PowerPoint, pages 2, 3, and 7. So you can see here, pages 2 of 7, page 3 of 7. So I filled them out just so you can see a mock version of it, right? And then I don't have to do 4, 5, or 6 on the back, but I do have to fill out 7 of 7. And that's it. So you want to do this with the patient. You want to have them look at what you write, confirm and verify that you wrote down the exact information. Okay. Now I'm going to take out, this is the sample, the dried blood sample card. You want to keep this, what do we want to call it? Hold on. I am forgetting the name. The preservative. You want to keep the preservative patch here, packet in this bag, because you're going to be putting this back in here. Okay. Now, here's the card. You're going to write down the patient's name on here, right? The collection date and their date of birth. And as you can see, here are the circles. Now, look at here. You can see it's like it's stuck. It opens like this because when you're making it dry, all you do is put it like that, like a little tent, and it gets to dry. Very simple. So I'm going to put this right next to me here. I'm going to take a Lansing device, my alcohol, clean my finger, Try it. I'm gonna get my Band-Aid ready. Okay, I'm going to twist the lancing device, just twist and remove. That's it. Okay. I'm going to take this to the side of my finger and it's contact. So I'm going to press it in, right? I'm going to press it in. And now is my blood. Good. I'm going to take my card. Let's see if I could do this on camera really well. I want you to be able to see it. Okay. All righty. And as you see what I'm doing? I am milking and then applying, milking and applying, because I want to fill up that circle. Milk and apply, milk and apply. One more. I'm typed A, so I have to get it all perfect. Look at that. Now I'm going to move on to my second one. And I'm going to milk and apply, milk and apply, milk and apply, milk, apply. Okay. Milk and apply. Oh, wow. Look at that. Gorgeous, right? Okay. Now, 2 is the minimum, but again, if you can get 3, like I have a really good finger stick here. So I'm an overachiever. I'm going to go for 3. Here we go. All right. Almost. And I get right to the perimeter, right to that circle. Okay, look at that. Isn't that gorgeous? There we go. All right, so I would be set. And now I'm going to put this card on the side. I'm going to go back to the patient, just wipe their finger. Okay. Apply. Whoops. Okay, apply the Band-Aid. Da, 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 da. And I'm done. That's it. Put this aside. And when this is fully dried, then you're going to put this kit all back together. You're going to put that dried card. Once this is dried, you're going to fold it back like this. And you're going to put it back in here with the preservative patch. And that's going to go back into the box, the kit, and back in here. Collect all of them and put them in your box. I think that's about it. Mariana, I'll come back to you. If there's any questions for me, I am happy to answer them.
Yes, thank you, Lucille. This was great. Melanie, is there anything that you would like to add? Would you like to run the test yourself? We are willing to see more blood on screen. So, Melanie, anything that you would like to add?
Well, that was commitment for sure, Lucille. But definitely I think helpful as a visual. So I did want to just mention that Beyond Type 1 has partnered with Enable in a lot of instances for these testing resources. But they're just one of several options out there in terms of autoantibody testing. And so, you know, I think one of the other ones that would be important to share with you is through the Barbara Davis Center in Colorado, through a program called ASK, A-S-K. And they actually use a similar method. And so the way that the testing is done is through this dried blood spot card as well. And so I think that that's important to know, though, as an organization, that there are different ways in which you can test for autoantibodies. And really, we as an organization are always looking at new ones and those that really consider budget and the populations that are served. And so really do appreciate the example, and certainly will come in handy no matter what type of test that you use. And that's it.
Any questions?
I had a question about our mobile programs who were on here getting access to those tests. Like, is there a link to I mean, would you just go to the askhealth.org and they provide the test, or how does that work, Mariana?
Well, we currently, as Melanie mentioned, we have worked before with Enable Biosciences. There are, however, different options that we can work with. It'll depend on many options. This year, for example, as part of our innovation grants, some mobile care clinics were able to provide and to do some of these testings themselves. However, we're also looking into ways in which we can make this sustainable, you know. So in some cases, if you have some budget that you could allocate for these purposes, that would be ideal. And in some other cases, it would be just a matter of reaching out and see what options there are. We're probably having the innovation grants next year. So that could also be one of these amazing projects. It could be an innovation project related or related to a type 1 screening. And there's different things that we could do. However, we're looking into ways in which we can motivate you enough so that you can start doing this in your own practice. Melanie, anything that you would like to add in this regard?
Yeah, so in terms of logistics for obtaining the actual testing kits, definitely reach out to us and we will connect you with the best partner based on a lot of different things, but we will facilitate that for you guys.
Any additional question?
Well, I had a question for Lucille. And my question is, so when I think about you were talking about autoimmune disorders and you were comparing, celiac and diabetes and so my question is, with celiac, just like diabetes, it sounds like something has to activate it, right? But with celiac, there's also gene testing you can do to see, which doesn't guarantee it, but if you don't have the gene, they think that you likely won't get there. So, but this the blood test that we're checking for, does that only show if it's in the early stages of activation, or does it show your proclivity for ever getting it? You're on mute, Lucille. Yeah.
I wanted to do that while Melanie was talking. So no, what it's going to show us is it doesn't show us how long somebody's had active autoantibodies. It just shows us the presence of. And the reason why that's important, Elizabeth, is to your point, they can wax and wane. So because somebody has positive autoantibodies, that doesn't mean that they will continue to have positive antibodies. That's a little bit of a gray area there, right? Because it sounds like, well, how do you not have positive antibodies over 3 years? But we have seen them actually not be positive. So we have to monitor. And of course, it's that word, that persistence. So that's going to tell us when someone has persistence positivity, that's going to tell us, yeah, the likelihood, but how quickly will they progress is going to be really based on age. I have to come back to that. And that goes back to metabolism also. So the younger the child, remember, I mean, gosh knows I don't have the metabolism of my 1-year-old grandson, right? But that plays into that development there. So we have to be really aggressive in the children. Not that we don't pay attention to the adult with positive autoantibodies, but they're going to progress slower. But to your point, how do we know how long that adult has had positive antibodies? So the key is really monitor, monitor, monitor.
But there's not a way to know outside of the risk factors that are listed so nicely on Beyond Type 1's website, as well as the slides. There's not the lack of the antibodies does not really tell us that it won't progress. It's not like a gene test that could show you your propensity.
Yeah, exactly. Exactly. And you know what? And I want to just mention this as well. I've worked in the pediatric population for a while, and I will tell you that the reason why I'm excited about this now is I will tell you, if we go back many, many, many years, we've been testing for autoantibodies. This is really not new, just like the therapies aren't new. We've had this ability to test, but we didn't have something as wonderful and as positive as far as delaying the onset as we have now, which is Tzield. And when we go back, if I were to go back maybe 25 years, I can remember parents saying, I don't want to check my other children because I know what the signs are. And to me, it was for them mentally straining to think they're waiting for the shoe to drop, when in fact it may not happen. But yet, when we look at how many autoantibodies and that persistency, we can say, yeah, it's going to. But I've seen now a shift where parents were once telling me, I got this. I don't want to know. Like one mom had 4 children. One had type 1 diabetes, the other 3 tested positive for autoantibodies. It was very psychologically difficult for her to hear that news. And yes, they did all go on to develop type 1 diabetes over time, but that didn't necessarily have to be the case. But whereas it was very traumatic for her, what we're seeing today is parents like, I want my child now monitored because there is this treatment that can delay the onset. So they feel this positive thing that they can do for their children rather than feeling helpless. So I've seen a paradigm shift in that area.
Melanie, your hand is raised.
Yeah, thanks. Absolutely. So, I would say, genetic testing is a different sort of phase of knowing risk for something, right? Whereas this autoantibody testing is really more at the activation phase. And I try to think about it like how we think about pre-diabetes in type 2, where potentially we see a slight elevation in glucose. Potentially we see someone takes a risk assessment, right? And they have lots of different factors that are kind of pointing in the direction of, let's say, an eventual type 2 diagnosis. But there is the art behind it, right? And so we have to take into consideration a lot of the things that Lucille was speaking about, age and family history and so on and so forth. But we also have to pair it up with other tests, like a C-peptide, to determine the level of beta cell function that is current within this person and all of that. And so although there is a consensus for now for general population screening, and we definitely have a consensus that's been around for a while that Lucille used in terms of monitoring for early stage T1D. I think we're still sort of young in this journey, and so we are now just really getting started when it comes to offering this autoantibody testing, which again I think about as more of a different entry point into the risk of eventual T1D. And we can quantify, research has shown us that those who test for 2 or more autoantibodies are at or very close to a 100% lifetime risk of insulin dependency, type 1 diabetes. Varies by age and all of that, but that is something that has been established by research.
And other than that, it is worth noting that these tests have 2 main objectives. I would say that the first one is to prevent DKA, which is a life-threatening condition. Many individuals with type 1 diabetes are diagnosed while having diabetes ketoacidosis, and we want that to stop happening. We want people to know that they have this higher risk of developing type 1 diabetes to prevent hospitalizations and other things that will be caused by diabetic ketoacidosis, including death, of course. And we know that many individuals are also misdiagnosed with a different kind of diabetes, a different type of diabetes that they don't actually live with. So these tests might provide additional information for us to get the right diagnosis, and that way to treat better and timely diabetes as it should. Lucille.
Yeah. Marianne, I also want to mention too, if I could tack on to what Melanie said, Elizabeth, the importance also of using, all the things that we have available, right? We're just monitoring with the blood sugars and all, but also with that C-peptide. Again, when you're looking at that C-peptide level, which is the ability of the beta cells to produce insulin. So you have the autoantibodies. The autoantibodies is not telling us on a time journey. They tell us presence. But if you see C-peptide level is dropping, right? If we watch that, that's going to tell us time. That's giving us some velocity there that we can attach onto and really say we've got to monitor somebody closely. Whereas if you do 6 months later and C-peptide level hasn't really changed at all, very different than someone losing their ability to make insulin or that C-peptide level really dropping drastically in the 6 months. So hopefully that helped you as well.
And I don't think that we have more questions for now, Elizabeth.
No,
Well,
does anyone
for-
want to unmute themselves? Does anyone else have a question?
Oh, there's a question here. Who can administer the sample kit? Specific title personnel or general staff? That's a great question for either Lucille or Melanie.
Yeah, so it definitely depends on which organization we're partnering with. The example that Lucille provided was the Enable kit, and that can be administered by really anyone, even the person who is testing can do it themselves. It's a clear, self-administration. But again, it kind of depends on which organization's test you're using.
And additional questions? No questions for now. Well, just a reminder, please help us with your answers to the survey. I just dropped the link there again. Please say it'll take you no more than 5 minutes, I swear. And those answers will be extremely useful for us to do a better job and for us to see what and how we can benefit from these learning experiences each other. Elizabeth, I think we're done.
Wonderful. Thank you so much, Lucille and Mariana and Melanie, for your time. And thank you all of our members for joining. I know this is a rapidly changing landscape now, something that had been kind of constant for a long time back in the juvenile diabetes days, right? And it's so fortunate that there's so much more education and options for early detection and treatment. So thank you so much for all of your time. And we hope to see a lot of you on our November 6th webinar on 2 mobile programs that are working on pediatric diabetes. So link on our website to join that, and we hope to see you all then. Have a great day.
A great day, everyone. Thank you for joining.
Thank you.